to talk about the debate, CEA, CES, and some updates of the Crest 2 trial. Okay, so thanks very much for the kind invitation. I come from Al-Andalus, from Andalusia, from Malaga, Spain, so I have quite a strong connection with Arabic culture. But impressive that here I lose all my baggage. At 1 in the morning, someone bring to my room and bring me some clothes and vestment to give the lecture. So it is, we can say that the level of evidence of the Arabia Saudi hospitality is 1A. Okay, let's go to the presentation. This is the introduction of the CEA case debate. CEA versus CAS versus best medical treatment. So we have to look for the best treatment for this patient. This is the reason Crest 2 was designed. We have some updates of Crest 2 trial. We will analyze when TIA seems to be superior, where CAS should be the less complications, when only best medical treatment is the best choice. And I will share with you also my personal journey the last 15 years doing carotid procedures from CEA to TICAR. That is a technique that we developed in Spain in some centers with a lot, and from CAS, and some take-home message. Well, the Crest 2 trial is a large multicenter clinical trial to evaluate the best way to prevent a stroke in asymptomatic patient, non-symptomatic. The trial tries to determine if best medical treatment is superior to revascularization procedure, CEA or CAS. So the trial is designed in two parallel studies, best medical treatment versus CEA plus best medical treatment, and best medical treatment versus CEA plus best medical treatment. So the primary outcome is the composite of a stroke and death within 45 days after randomization, and a stroke is bilateral vessel up to 4 years. So this is two arms study, and we can see that most of the specialists included in the trial are not vascular surgeons. So carotids is not a thing like the aorta or CLA, mostly from vascular or interventional radiologists. Here we have cardiologists and neurologists playing the game. So Crest 2, one of the good things, they adopted a very rigorous procedure for evaluating, monitoring, and approving operators, because some previous trials had some problems. Each trial has a recruitment time of 1,204 patients with more than 70% asymptomatic carotid stenosis, mostly diagnosed by ultrasound. The preliminary findings prior to the trial suggest that best medical treatment may be equally effective in prevention for selective patients, high-risk patients. And we also have to talk about the Crest 2 registry, not the trial, who was established to allow for recent experience for applicant stent operators, because what was the problem with other trials? The lack of experience in the stent arm. So this is the center that are part of the Crest 2 trial. We have centers from mainly United States and some centers, few centers from Europe. So it is mostly an American. The Crest 2 registry is a prospective multi-center observational and establishes to ensure patient safety and give stenting the best possible chance to demonstration the benefits. This is the registry prior to the trial. So the registry has included almost 10,000 patients and provides the most contemporary result for transfemoral carotid artery stenting. It's a mixed record of asymptomatic and symptomatics, and with a 30-day stroke rate 1.8% and 30-day stroke death 6%. And the registry has facilitated assembly of a high-performing team of stent operators for the Crest 2 trial. That was the problem with other trials. Because this was a previous good trial that was designed in Europe, the Space 2 trial, but it has a premature closure. It was a 3-arm design trial, but was closed due to a low enrollment rate. So it has not enough power. And the recruitment challenge was mainly lack of incentive and lack of stenting self-awareness, as stenting was not supported. But we have some lessons from a Space 2 trial, and it's studying these days, all this, it was surprising for me seeing how some of the lessons learned from Space 2, they talk about TICAR, no? That is surprising. And I asked myself, why TICAR is not included in Crest 2 trial? Well, TICAR showed promising results. It's not allowed in Europe, it's mostly in United States, but in United States growing very fast. Even now it's more performing than transfemoral carotid artery stenting. But finally, TICAR is putting a stent in the carotid through the carotid access with flow reversal. So, and the main thing about TICAR, I think we cannot compare with other techniques, is that TCAR allowing the surgeon to place the stent. I mean, cardiologists cannot do it, interventional radiologists cannot do it, neuro cannot do it. So in a world where carotid artery disease is managed by many other specialties, finding only doing TCAR is complicated in my opinion. Some technical aspect of the TCAR is that you have a small incision, you access the carotid through here, but finally you have to use this kind of device to reverse the flow. And we have to be careful because with high flow, some patient doesn't tolerate, and you need to stop. But finally, you put a stent. Okay, so let's go back to Crest 2 after some talks of TCAR. The result of Crest 2 we are waiting because they could influence future guidelines for treating asymptomatic KD, and we need to focus more toward best medical treatment in certain populations. The previous trials indicate similar outcomes for CEA and CAS in symptomatic patients, but more data is needed in asymptomatics. And when we compare CEA versus CAS, the referee patient population-based treated for optimal outcomes differ. So we know that some patients are going to do better with endarterectomy and others better with CAS. Especially age, aortic arch, vessel anatomy, and maybe plaque characteristics of the carotid will affect the outcomes. And carotid plaque characteristics, in my opinion, is an important issue. We need to see future results because what we know now from the result from Crest, they analyzed the first 500 patients underwent standardized carotid ultrasound evaluations. But the information that we have is that the patient has a diverse range of stenosis by velocity criteria, but the findings implying a lot of heterogeneity in the natural artery of the plaque behavior. So we don't have enough data to know which plaques are going to do better or worse, which any of the textures, no? So maybe in the future we'll have this answer, but not yet. And the current evidence that we have, the last update that we are having from Crest 2 is coming from this summer. They finished the recruitment on the surgical arm. And the data suggests that, yes, the hypothesis is okay, best medical treatment reduces stroke risks, and it's similar to CEA and CAS in some patients, but especially in the high-risk patients. That CEA might be the best option in patients with low surgical risk, but elderly. Why? Because the arch, probably. That CAS has shown a slightly higher peri-procedural stroke rate than CEA in older patients, and it is the navigation of the arch, and it is where TCAR may play a role, avoiding the arch. And they also, we have the data that CAS is obviously a less invasive procedure with faster recovery, and maybe could be an option preferred for younger or high surgical risk patients, because we know it's associated with less myocardial infarct. So I will tell you my small journey of the last 15 years. And about the CEA was the first and only option during my training, probably like most people here in the room. Later, I had my own learning curves, and I would say that my first 20, 30 carotid artery stenting were quite stressful, and once you need to learn to work with distal filter, MoMA, whatever. And then I lived personally the TCAR explosion in my center. We are part of the research study. And we did a lot of TCAR case, but now I'm doing more transfemoral CAS with the new device, with the double measure stents, with new system protection. And in my experience is that TCAR, even nowadays, should never be offered as a less scar procedures, because you cannot offer this to the patient. It's not a CEA, it's putting a stent in the carotid. And if it's contraindicated a stent, it's contraindicated for TCAR. And it is a hybrid procedure that takes the best and the worst of the two worlds. So I have seen complications during TCAR that probably with a carotid endarterectomy we will never see. And just some take-home measures to the audience is that Crest 2 shows that best medical treatment has become a strong option for some selected patients, probably elderly and the most high surgical risk. We don't need to operate them if they are 70% asymptomatic stenosis. The CEA and CAS remains the best options in different certain populations. And the Crest 2 ongoing results are key to getting future decisions and guidelines, supporting a more individualized approach to our patients. So it's not the moment to say just most 70 size, CAS or stenting or CEA or medical treatment depending on patients' characteristics, anatomy, and plaques. And there is still a need to identify which lesion, particularly anatomically, plaques will benefit more from CEA or from CAS. Thanks very much. This is my family will of experts, and I always tell to them that newer technologies or new toys never may for the improved outcome, but they don't replace never good technique and judgment. And the same with carotid and CEA. Thank you very much.
Thank you very much, Fernando, for this very